Doctor, shall I start my topic? Hope somebody is listening to this topic. Listen. Yeah, yeah. So as such, there is no as such causes, symptoms. Treatment wise, it's almost everything like similar to the gynae TB. So the main difference is I'll be talking about genital TB in ART, and then what are the problem we faces, and then what are the issues we can have during the ART treatment, and then what is the outcome in TB patients and infertility patients with TB. So basically, it's an important cause of infertility, especially in places like India. Often it is underdiagnosed because of its silent presentation, and then it's quite challenging with ART outcome. So it's an important infertility factor for infertility in India, and then its incidence is about 5 to 10%, and then this is 20 to 40 years is the age group which is usually affected. So as you know, prior like hematogenous spread, fallopian tube is most commonly affected, followed by endometrium, and then followed by the cervix, vulva, vagina. Shruti doctor, I was expecting you. So the clinical features are like mostly they are asymptomatic. They may have some menstrual abnormalities. In infertility, the whenever there is an unexplained infertility, always consider one of the diagnoses as genital TB. And then if somebody with chronic pelvic pain, any TO mass which is like other than those endometriosis after ruling out PA disease, kindly consider this TB. And then any constitutional symptoms also consider TB. So, as you know, when to suspect TB in a patient, and then as it is has a silent presentation, always have a high suspicion of TB, especially in infertile patients. These are the few tests which we have to do, but in infertility, what we generally does is this AFB molecule. That is generally we do gene expert. See, when there is a thin endometrium or when there is a recurrent fluid in the cavity, generally we post the patient for hysteroscopy. And in hysteroscopy, if it is any suggestive of TB or like generally in few patients, we take a biopsy and we send it for gene expert. That is CB NAT. So as you all know, it is an ATT treatment, which is of 6 months treatment. So the impact in as such, the impact in infertility is because of the involvement of a female genital tract. Quite post TB, there are a lot of damages in the tissues like tubal damage, block, irreversibility, and then endometrial damages, especially the basal layer. So there is a poor chance of implantation as the endometrium will be thin. And then if there is an ovarian involvement, the reserve will be less. So even after proper ATT treatment, the conception rate is low because of those damages. So these are the few ART options are there, IVF ICSI. So what are the challenges we face in ART is especially the thin endometrium because of the damaged basal layer. It's very hard to get the endometrium. Even we put hysteroscopy, PRP, whatever we do, also it's very difficult in getting the endometrium. And then if we get the endometrium also, if we go out with embryo transfer, even with like 5 mm, 6 mm, most of the time we end up in having a negative beta SCG. So this is quite a challenging condition, especially post TB. But there are few TB patients where they are diagnosed as a pelvic TB. They have taken a proper ATT treatment for 6 months, and then after 6 months they had a very beautiful triple line for whom we have transferred, and they had pregnancy too. So we had such kind of patients also, and then we had this patients like thin endometrium patients also. So especially thin endometrium and recurrent fluid in the cavity, always consider about TB and send the PCR for endometrial biopsy for gene expert or PCR, whatever. So if at all, if there is some amount of implantation also, but there is a more chance of abortion risk is also there. So if there is more of endometrial damage, then think about the surrogacy. So before ART, when somebody is coming to you, TB patients on ART, kindly postpone the treatment till they finish the 6 months of cycle, and then if there is change, if there is difficulty in getting endometrium, try all these PRP, GCSF, it is like colony stimulating factor, stem cell therapy. All these helps in getting the endometrium to an extent, but we cannot expect like 7-8 mm, at least to an extent of 6 mm. So consider donor oocyte if in case of POR, consider surrogacy in case of severe endometrial damage. So always when there is a T patient comes to you for infertility treatment, counsel them, tell them there is a difficulty in getting endometrial thickness, and then if there is a thin ET, there is a relatively less success rate, and then there is a more chance of adhesions thin endometrium, endometrial damage. Tell them about the surrogacy also. So in general, the pregnancy outcome is lower than non-TB patients even after ART treatment. There is a more miscarriage rate is there, and then even the live birth rate is poor. And then we have a better outcome only when the tube is involved. In general, if only the tube is involved, the outcome is better. But if there is any endometrial involvement, the outcome will be like little worse. So always consider TB when there is an unexplained infertility, thin endometrium, any unknown TO mass, any intrauterine adhesions. There are few patients who doesn't have any history, like because of the hazy pattern of endometrium. When we post them for hysteroscopy, we can see some intrauterine adhesions. In these conditions, always consider TB, refer them to our pulmonologist, and then start them with the ATT treatment. So always consider in case of unexplained infertility, thin endometrium, fluid in the cavity, any unexplained TO mass, and then any intrauterine adhesions. Always do gene expert, and then PCR, anything. But nowadays, we are not sending all those menstrual blood for TB. It's always better to go ahead with the direct endometrial biopsy. So treatment as per national program, and then always before starting any ART treatment, or at least before starting endometrial preparation, let them complete the ART treatment. So I think I'm done with the topic. This is already a known topic, but I want to give importance to that ART outcome in TB patients. So I have told everything. Still, like if you guys have any doubt, you can ask me. I'm done with my presentation.